patients. But when the pandemic hit, we just got a surge of highly acute and critically ill patients. And that sort of really created a resource drain almost immediately, because, you know, in the early days of the pandemic, patients were presenting with non-specific cough, generalized aches, like any person that would have a viral syndrome would come in. And then it seemed like over the period of a day or two, patients were coming in acute respiratory distress. And we really didn't know what was going on, because the physiology that was being presented to us was not matching the patient's clinical picture in terms of the majority of patients that were coming in. So what do I mean by that? You would have somebody that would come in, you know, and who was a little tachypnic or breathing fast, and, you know, saying that they were having, you know, some difficulty breathing, may have had a cough, may or may not have had a fever over the past several days. And then we would take their vital signs and their oxygen saturation would be 60%. Now, a normal oxygen saturation should be above 95% on room air, meaning you're not having any supplemental O2. And you would look at these patients and the first thought was, oh my God, like we need to start them on BiPAP, or we need to, you know, intubate them. And that's sort of what happened early on. We kind of didn't understand the physiology and the characteristics of this virus, and the data out of China was not useful. The data out of Italy had not really been put out there yet. So, you know, we were kind of getting an onslaught of these, you know, majority of what didn't look clinically sick patients, but who physiologically seemed very, very sick. And we didn't know how to treat it. So there was a shotgun approach basically early on to intubate these patients earlier. And now we're seeing the consequences of that, which has been a spike in mortality. And it's been really rough, because I've seen both hospitals I work at transform completely overnight, which has its own sort of, you know, plays on your mind a little bit, you know. So what I've seen is my hospital go from, and Lincoln in particular, go from like your normal, you know, acute care center with, you know, about 250 to 280 inpatient beds that has, you know, your regular ICU capacity, you know, anywhere from 25 to 40 beds. Now we have like 150 ICU beds.